Hi, today I will be talking about international guidelines for the management of sepsis and septic shock published in 2021. The recommendations are intended to provide guidance for the clinician caring for adult patients with sepsis or septic shock in the hospital setting. Recommendations from these guidelines cannot replace the clinician's decision-making capability. Hospitals and healthcare systems are recommended to use a performance improvement program for sepsis, including sepsis screening for acutely ill patients. It is a strong recommendation with moderate quality of evidence. Initial resuscitation, sepsis and septic shock are medical emergencies, and the recommendation is to start treatment and resuscitation immediately. It is a best practice statement. For patients with sepsis and septic shock, it is suggested to start IV crystalloid fluid at the rate of 30 ml per kg within the first 3 hours of resuscitation. It's also suggested to guide resuscitation to decrease serum lactate in patients with elevated lactate level. Weak recommendation with low quality evidence. Fluid management. For adults with sepsis or septic shock, it is recommended to use crystalloids as the first line of fluids for resuscitation. This is a strong recommendation with moderate quality of evidence. It is suggested to use balanced crystalloids instead of normal saline. It's a weak recommendation. It is also suggested to use albumin in patients who received large volumes of crystalloids. Vasoactive medications. For adults with septic shock, recommend using norepinephrine as the first-line agent over other vasopressors. This is a strong recommendation. It is suggested adding vasopressin at 0.03 units per minute to norepinephrine in patients with inadequate mean arterial pressure levels. Weak recommendation, moderate quality evidence. Suggest adding epinephrine to norepinephrine and vasopressin if inadequate mean arterial pressure levels. Weak recommendation, low quality evidence. In patients with septic shock and cardiac dysfunction, suggest adding dobutamine to norepinephrine or using epinephrine alone. Weak recommendation, low quality of evidence. In a setting where norepinephrine is not available, epinephrine or dopamine can be used as an alternative. For adults with septic shock on vasopressors, it is recommended to target mean arterial pressure of 65 mmHg or higher. This is a strong recommendation with moderate quality evidence. Diagnosis of infection. Adults suspected with sepsis but unconfirmed infection recommend to re-evaluate and search for alternate diagnosis and discontinue empiric antibiotics once an alternative cause of illness is found. Adults with possible sepsis without shock recommend assessment of infectious versus non-infectious causes of illness. These are best practice statement. Source control. Adults with sepsis or septic shock, it is recommended to rapidly identify or exclude a specific anatomical diagnosis of infection that requires emergent source control. Prompt removal of intravascular access devices that are a possible source of sepsis or septic shock is recommended. Both of the above are a best practice statement. Timing of antibiotics. Adults with possible septic shock or a high likelihood of sepsis, it is recommended to administer antimicrobials within 1 hour of recognition. This is a strong recommendation with low quality of evidence. For adults with possible sepsis without shock, antimicrobials should be administered within 3 hours of sepsis being recognized. This is weak recommendation with low quality of evidence. Antimicrobial choice. Adults with sepsis or septic shock at high risk for MRSA infection recommend using empiric antimicrobials with MRSA coverage. It is a best practice statement. Who are at low risk for MRSA, it is suggested against using empiric antimicrobials with MRSA coverage. This comes with a weak recommendation, low quality of evidence. Adults with sepsis or septic shock who are at high risk for multi-drug resistant organisms, it is suggested using 2 antimicrobials with gram-negative coverage for empiric treatment. Who are at low risk for multi-drug resistant organisms, it is suggested against using 2 antimicrobials with gram-negative coverage. Both of the above come with a weak recommendation and very low quality of evidence. Antifungal therapy. Adults with sepsis or septic shock who are at high risk for fungal infection, it is suggested using empiric antifungal therapy. Who are at low risk for fungal infection, it is suggested against empiric use of antifungal therapy. Both of the above come with a weak recommendation and low quality of evidence. Risk factors for fungal infection: neutropenia, immunosuppression, long ICU length of stay, central venous catheters, total parenteral nutrition, broad spectrum antibiotics, gastrointestinal tract perforation and anastomotic leak, acute renal failure and hemodialysis, emergency hepatobiliary surgery, HIV infection, solid organ transplantation, high-dose corticosteroid therapy, stem cell transplantation. Biomarkers. Adults suspected of having sepsis, it is suggested measuring blood lactate levels. It's a weak recommendation with low quality evidence. This should be part of a sepsis bundle. It is suggested against using procalcitonin plus clinical evaluation to decide when to start antimicrobials in patients with suspected sepsis or septic shock. It is suggested using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials. Both of the above come with a weak recommendation, low quality of evidence. Duration of antibiotics. Suggest daily assessment for de-escalation of antimicrobials over using a fixed duration of therapy and shorter over longer duration. It's a weak recommendation, very low quality of evidence. Ventilation. Adults with sepsis-induced hypoxic respiratory failure, it is suggested to use high-flow nasal oxygen over non-invasive ventilation. Weak recommendation with low quality of evidence. For adults with sepsis-induced acute respiratory distress syndrome, it is recommended to use low tidal volume ventilation strategy, 6 ml per kg. It is a strong recommendation with high quality of evidence. Adults with moderate to severe sepsis-induced ARDS, it is suggested to use higher PEEP. It is suggested to use intravenous neuromuscular blocking agents. Weak recommendation, moderate quality of evidence. It is recommended to use prone ventilation for more than 12 hours per day. This comes with a strong recommendation, moderate quality of evidence. Corticosteroids. Adults with septic shock and ongoing requirement of vasopressor therapy, guidelines suggest using IV hydrocortisone at a dose of 200 mg per day given as 50 mg every 6 hours. It's a weak recommendation with moderate quality of evidence. Blood products. For adults with sepsis or septic shock, guidelines recommend using a restrictive or liberal transfusion strategy with packed red blood cells when the hemoglobin is less than 7 gram per deciliter. Strong recommendation with moderate quality of evidence. Venous thromboembolism prophylaxis. Adults with sepsis or septic shock, it is recommended using pharmacologic VTE prophylaxis unless a contraindication exists. Recommend using low molecular weight heparin over unfractionated heparin. It is a strong recommendation with moderate quality of evidence. Renal replacement therapy. Adults with sepsis or septic shock and acute kidney injury who require renal replacement therapy, guidelines suggest using continuous or intermittent renal replacement therapy. It is a weak recommendation with low quality of evidence. Glucose control. Adults with sepsis or septic shock, it is recommended to initiate insulin therapy when blood glucose is greater than 180 mg per deciliter. Following initiation of insulin therapy, target blood glucose range is 140 to 180 mg per deciliter. Strong recommendation, moderate quality of evidence. Nutrition. Adults with sepsis or septic shock who can be fed enterally, guidelines suggest early enteral nutrition within 72 hours. Weak recommendation, low quality of evidence.